So we'll talk in this talk on a number of new developments in the area of fungal diseases, and starting with Aspergillus. We have known Aspergillus infections mainly in patients with high risk, like hematology patients who receive stem cell transplants, but we are now seeing more and more infections with Aspergillus in the so-called intermediate risk patient groups, and especially in those in the ICU. And they have several risk factors, including corticosteroid use, influenza, which I will talk about a little later, COPD, or the use of other immunosuppressants. So we now have a spectrum of risks, from very high risk in the classical risk groups to the very low risk groups, and the ICU patients are increasingly important, and we have to think of Aspergillus disease in these patients, especially when they are on corticosteroids. The diagnosis is difficult in those patients, whereas in hemato-oncology, in neutropenic patients, we have the classical signs on the chest X-ray or CT scan, like the halo sign or the air crescent in late-stage disease. Usually we don't see those signs in the non-neutropenic patients in the ICU, and they may have all kinds of infiltrates that you know of in the ICU, which do not discriminate between Aspergillus or any other disease. So diagnosis is quite complicated. Of course, we have BAL or tracheal aspirate cultures and stains, which may be confusing because they may reflect colonization rather than infection. And as you see in this series from Belgium, the sensitivity is quite low, as we are aware of in all aspergillosis patients. The Aspergillus antigen, galactomannan in serum, which is quite sensitive in neutropenic hematology patients, is much less sensitive in non-neutropenic patients, and in the ICU patients with aspergillosis, the outcomes are quite poor. But then we have the Aspergillus antigen, galactomannan, in the BAL fluid, which is quite sensitive in these patients. Most are positive, and also the specificity is higher than for culture. This is the way to go in terms of diagnosis. It's very important not only in the ICU, but in general to implement your galactomannan if possible, if it's available in your area, and then do it on the BAL also in patients who may have invasive aspergillosis in the ICU. So now influenza, and this is really new. In the past few years, we have been seeing an association between H1N1 influenza and invasive aspergillosis. Reports have come from all over the world, but this is the area, the situation in Europe, where both in Belgium and in the Netherlands, about 20 to 25% of patients who were admitted with severe influenza pneumonia in the ICU had a co-infection by Aspergillus species. And this is the study that is in press from my country, where in 8 university medical centers, 25 out of 110 confirmed influenza patients were shown to have co-infection with Aspergillus. Corticosteroid use is the main risk factor here, probably. And in terms of diagnosis, again, BAL galactomannan was the most sensitive way, although serum galactomannan was also positive in quite a high percentage of patients. So again, quite important to have the galactomannan assay, if possible, in your laboratory. Mortality was quite high, was more than 50%, and I'll come to speak on azole resistance. In this population in our country, 30% of isolates were azole resistant, actually. If you see the course, over time, divided into the patients who survived and those who died, you'll see that this is a very rapid disease. Patients were only a few days after the onset of their influenza symptoms when they were admitted to the ICU and ventilated. And as you see, the diagnosis of invasive aspergillosis usually happened only a few days after the ICU admission and the diagnosis of influenza. And in terms of antifungal therapy, you see the trend that those who had late start of therapy tended not to survive. And indeed, there has been this relationship between the time of influenza diagnosis and start of antifungal therapy in terms of survival, and those who were more than 7 days or so after the onset of influenza all died. So in practice, what could be the scenarios in the ICU? One is that you encounter a positive culture growing Aspergillus in a tracheal aspirate or in any material from your ICU patient. It's important then to assess whether the patient has risk factors for invasive aspergillosis, such as COPD or steroid use or influenza. And if there's any sign on the chest X-ray or CT, it would be very important to do a BAL and obtain a Galactomannan sample, and in the meantime start treatment if patients have these risk factors. The other scenario would be that you do a BAL for another reason, for any diagnostic reason, and find a positive Galactomannan. Again, then, if the patient has any risk factor as mentioned, this would mean a probable invasive aspergillosis and require treatment. In terms of new treatments, we have seen the study comparing isovuconazole, a new azole, versus voriconazole, which of course has been the most important therapeutic drug for invasive aspergillosis. And this was a randomized trial that has been published in the Lancet earlier this year. In patients with invasive aspergillosis, most hematology patients, and the outcomes were very interesting in that the primary endpoint, 6 weeks mortality, was really similar between isovuconazole and voriconazole randomized patients. And also the overall response, 35 versus 36%, was similar. In terms of side effects, it seems that isovuconazole is a little bit safer than voriconazole. Hepatics adverse events, the skin adverse events, and the ocular adverse events were significantly lower with isovuconazole. So as long as we have azole-susceptible Aspergillus, isovuconazole may be a very interesting drug comparable to voriconazole. Another interesting trial has been combination therapy for invasive aspergillosis, published last year in Annals of Internal Medicine. And here, in this randomized double-blind study, voriconazole, the standard therapy, was compared to the combination of voriconazole with an echinocandin, an idilafungin, and there was a strong trend towards a lower mortality with the combination therapy. Although this was the primary endpoint, the difference was just not statistically significant. But also in mortality, there was a trend towards lower mortality, again, not significant for the combination. Now, in a subgroup analysis of the patients who had a positive Galactomannan defining their probable invasive aspergillosis, which was the majority, about 80 to 85% of the whole group, the difference in mortality was significant, favoring the combination. This is just a post hoc analysis, but together this quite strongly suggests that the combination may be useful in patients with invasive aspergillosis. especially if they have a positive serum galactomannan test. Now, talking about resistance, there are two routes of acquiring resistance. In general, this will be in the hospital, where during therapy the isolate will become resistant. But the other route, of course, is in the environment, where the use of fungicides may lead to development of resistance in the environment, which then is being inhaled by the patient and brought into the hospital. And this seems to be a major route in azole-resistant aspergillosis. We have seen the advent of a number of mutations in the Aspergillus gene during the past 20 years or so. Excuse me. And this has led to quite widespread resistance, although at a low level, which was first discovered in Europe, but has been seen in the Americas and in Asia and Australia as well. This is the map, which is not quite up to date, because this is the status of January 2016, I think. And we now have seen an excellent paper from Thailand, which is just online in medical mycology, where in Thailand soil samples were collected, and especially in the Bangkok area and surrounding provinces, there was about 3% of azole resistance, again, with importantly with the same mutation. So it's here, and in that paper there is a review of all the surveys in Asia showing resistance, although at a low level of around 3 to 10% in most of the Asian countries. So it's there in the environment. In our country, resistance is now 7% overall, with areas with very high resistance. And actually, in some hematology and ICU units, we now have up to 30% azole-resistant Aspergillus. Thank you very much. So this is our hospital, and when we sampled the 3 pots here around the entrance, and also when we sampled garden centers, nursery, compost, and leaves from nature, at every site we found resistant Aspergillus, azole-resistant Aspergillus to be present. And this is really, now we know from the environmental use of fungicides. So for Aspergillus, we have to realize, just as a summary, that aspergillosis is increasing in the non-classical hematology patients, especially those who are on corticosteroids or have severe influenza. BAL Galactomannan is the preferred diagnostic in the ICU. Voriconazole or isovuconazole are therapy of choice. We have now the data on combination therapy, and in case of resistance, ampho-B, preferably liposomal ampho-B, would be your second-line therapy. And we are seeing increasing rates of azole-resistant Aspergillus also in Southeast Asia. If we now switch to Cryptococcus, it's important to notice that the modern cryptococcal meningitis therapy research all started in Thailand. In this paper from the Bangkok and Ubon Ratchathani universities, where they first introduced the early fungicidal activity as a measure of effectiveness of antifungal drugs, comparing combination therapies, where you see that the decrease of the number of colonies in the CSF is very different, which is a very good measure of effectiveness, and here favoring the combination of amphotericin B and flucidoside. And then from a study from Vietnam, it was shown that this really has an impact on survival rates. Again, the combination of ampho-B and flucytosine being superior in terms of survival and in terms of early fungicidal activity, amphotericin B plus fluconazole being second best if flucytosine is not available. Other interesting Cryptococcus research is the timing of start of antiretroviral therapy after the diagnosis in this randomized trial published a little more than a year ago. This was compared between 2 weeks and at least 5 weeks after onset of antifungal therapy, and the trial was terminated prematurely because of the superiority of late start of antiretroviral therapy with a significantly increased mortality if you start ART early, and this probably has to do with the onset of immune reconstitution, iris. So a very clear message to defer the start of ART in these patients. And finally, again from Thailand, in collaboration with the groups from Vietnam, in collaboration with the groups from Thailand and Indonesia and a number of African countries, the dexamethasone adjunctive therapy in cryptococcal meningitis, just published earlier this year, the so-called Cryptodex trial, where there was a very significant advantage of adding of not adding dexamethasone, again terminated earlier because of a higher mortality rate in patients starting on dexamethasone. Dexamethasone worsened the fungicidal activity, and it brought about additional clinical adverse events, including infection, renal insufficiency, cardiac events. And interestingly, there was no benefit of dexamethasone on iris, so no role for dexamethasone in cryptococcal meningitis. So in summary, early fungicidal effect as a very important measure. And interestingly, all the research actually has come from South Asian countries, which really boosted the knowledge on cryptococcal meningitis. Combination therapy, defer the initiation of ART and don't use dexamethasone. Now, a little bit on mucormycosis, which, as we know, is very difficult to treat and associated with very high mortality. Until now, amphotericin B has been the only drug that has really been effective. We know that posaconazole is active. And then there has been this recent study, which is only a small open-label study on high dose of liposomal amphotericin B in patients with mucormycosis. And in this study, which was non-comparative, the response was quite favorable, around 30 to 45%. And also let me see where it is, the mortality was around 35, 38% after 12 weeks, which is really comparable with other trials. So although it's not comparable, the drug seems to do at least as well as the conventional therapy. The other very interesting study has been the small study on isovuconazole, again, on 37 patients with mucormycosis, where they did a retrospective historical control comparison to amphotericin B, so it was not a comparative trial, with very similar outcomes as compared to the historical ampho-B groups. So interesting options for mucormycosis. Now finally, let's switch to Candidemia and invasive candidiasis to see what's new here. First of all, prophylaxis. We have now seen a number of prophylaxis trials in the ICU, which all actually have been negative. The new one is this, quite a large trial of micafungin in the ICU in terms of prophylaxis, with no difference in terms of incidence of invasive candidiasis or mortality versus placebo. And if you look at all the large candidiasis prophylaxis trials in the ICU, some have shown some decrease in incidence of invasive candidiasis, but none of them has shown an effect on mortality. So in general, there is no support for prophylaxis in the ICU other than the well-known groups in the guidelines, such as high-risk liver transplant recipients, etc. So then how to start antifungal therapy in patients suspected for invasive candidiasis? A very well-known score has been the Candida score from the ICU groups in Spain, where patients receive points when they have colonization with Candida at multiple sites, receive TPN, are surgical patients, and most importantly, have severe sepsis. So this is really focusing on patients not just with sepsis symptoms, but those with severe sepsis according to the definitions, and then have additional they need one additional risk factors. And in Spain, this really is shown to predict invasive candidiasis. The difficulty with these kind of scores is that they are really validated locally and very dependent on the situation in the ICU. For instance, in Australia, this was found to be less useful, with a very low sensitivity, an extremely low positive predictive value, and so you could easily flip a coin rather than calculate the score to see whether a patient had invasive candidiasis. So these kind of scores do not apply automatically in any other country or setting. How about biomarkers? Until now, the results, I think, have been a little bit disappointing. We have beta-D-glucan, some have Candida albicans germ tube antibodies, some have Mannan antigen and antibodies. PCR is underway, and in general, as you can see in this study, the specificity is very low. In colonized patients, control patients without invasive infections, these biomarkers have been positive at a very high rate, whereas the sensitivity in patients with proven invasive infection have been disappointing, around or below 50%. So if you do the calculations, they won't really help you in most of the settings if you have a high-risk patients. So for screening, they might be interesting, but in high-risk patients, you still end up with a very high false positive rate, and sensitivity is not good enough to rule out candidiasis if the test is negative. And also combination of tests will not be extremely helpful, as still the false positive rates in all the scenarios they tested here with combination of tests, false positive rates will be extremely high, and sensitivity is too low to treat individual patients or to rule out the disease if the test is negative. Another trial on empiric echinocandins in abdominal candidiasis. Later this weekend, we will talk a little bit more about abdominal candidiasis. For now, just this very interesting trial that has just been published this year, where patients were randomized between empirical therapy with micafungin or placebo if they had high-risk abdominal surgery and were in the ICU. And again, this is a negative trial. There was no difference in terms of proven candidiasis in the micafungin and placebo group. So micafungin did not prevent abdominal candidiasis in these patients, and there was not even a trend towards a lower mortality in the micafungin group. So again, no support for empirical therapy in the large population of high-risk abdominal surgery patients, and we will have to do better in terms of diagnostics. So what should we do then in practice with all these negative studies? First of all, it would be important to select patients with severe sepsis and to be selective in terms of empirical therapy and just focus on the ones who are the sickest and have severe sepsis. And then my personal view would be to assess the risk factors, GI surgery being the most important. If we know that patients are colonized, if they have no response to broad-spectrum antibiotics, or if you do surrogate markers and they turn out to be positive, these would be risk factors to steer your decision towards starting empirical antifungal therapy, and that would be an echinocandin, preferably, as I'll show you in a minute. So how can we do better if all these trials have been so disappointing? Well, that's by sticking to our treatment guidelines. And we now have two sets of recent guidelines. The US IDSA guidelines just published earlier this year, and the European ESCMID guidelines. And the European guidelines favor any of the three echinocandins as the first choice therapy, and actually that's what also the IDSA guidelines now do. So they are really in agreement that an echinocandin, any one of the three, would be your first choice in virtually all patients with invasive candidiasis. And in the American guidelines, you'll see that there are a few what they call acceptable alternatives if there's a reason not to give an echinocandin, which are fluconazole, voriconazole, or liposomal amphotericin B, but the strong recommendation is for the echinocandins. Why is that? Basically, that's because of this trial, New England Journal of Medicine, now about 8 years ago, comparing anidilafungin to fluconazole, where fluconazole did not do very well in terms of candidiasis treatment, really disappointing outcomes with a significant difference favoring the echinocandin. And also in terms of mortality, there was a strong trend towards lowering mortality by starting an echinocandin. Again, about 15% difference in outcome between the two study arms favoring the echinocandin and anidilafungin. And interestingly, if you break down these patients, the ones who were infected by Candida albicans showed the largest difference, about 20%, favoring anidilafungin. And that's very interesting because the Candida albicans isolates all were susceptible in vitro to fluconazole. So this is not a matter of susceptibility, it's just the superior effect of the echinocandin. And a similar trend was seen for the non-albicans isolates. So do we have any new data since the publication of that trial? Yes, we do. This is a very large pooled analysis where all patients who had been entered into any comparative trial with candidemia or invasive candidiasis were pooled at a patient level, so that we have a sort of virtual trial of almost 2,000 patients who had been randomized and blinded and treated with any antifungal agent. We chose mortality, 30-day mortality, as a very hard endpoint. And what we saw is that there were a few factors influencing mortality, as you could guess, increasing age or increasing Apache-2 scores, which of course has been designed to predict mortality. But there were two interventions that were independently associated with improved outcome. and that was randomization to any of the echinocandins in any of these randomized blinded trials, and removal of the central line anytime during therapy. And both were associated with a reduction of about 50% in terms of 30-day mortality, very significantly so. So that constitutes what I now call our golden rules of candidiasis treatment. So treat early, remove the IV catheter, and start patients on an echinocandin. There has been a second trial comparing an azole to an echinocandin now, which was just presented at the ECCMID conference this year and hasn't been published yet, and that's the comparison of isofluconazole versus caspofungin. So another azole, another echinocandin for Candidemia and invasive candidiasis. A very large trial including 450 patients, and basically similar results to that of the previous trial. Success rate with isofluconazole disappointing, only 60%, caspofungin 71%, a significant difference favoring the echinocandin, and this was true, or the same trend was seen again at all endpoints and in terms of mortality. So we now have two trials with very similar results, two echinocandins being significantly better in terms of success rates for candidiasis than the two azoles, so a very clear message. So in summary, we have to realize that most of the Candidemia, invasive candidiasis cases come from intestinal colonization. Prophylaxis, empirical therapy, biomarker-driven therapy are not supported by published trial data, although we have to find a way to treat these patients. And if we do, we now see a lot of data showing superiority of the echinocandins here. Both international guidelines now favor echinocandins as the first choice of Candidemia and invasive candidiasis, and I think we have a clear message now in terms of treating these patients. So this will end my talk, and we'll have time for discussion after the next talk, I think. Thank you very much.